And welcome to Camellia Rose chapter of the Links Incorporated, Session 2 of Breast Cancer Awareness and Women's Issue. We are honored to have Dr. Erin Bowman, Dr. Alexis Ford, and Dr. April Spencer as our guest panelists. Dr. Erin Bowman is a native of Philadelphia, Pennsylvania. She's a graduate of Spelman College and received her medical degree from Boston University School of Medicine. She did breast surgery training at Morehouse School of Medicine and a breast surgery oncology fellowship at Emory University School of Medicine. She has been practicing surgical oncology for over 7 years. She currently practices at Atlanta Breast Care. Welcome, Dr. Bowman.
Thank you. Thank you for having me.
Dr. Alexis Ford is from Ontario, Canada. She attended the University of South Carolina undergrad and the University of Southern California Medical School. She received her obstetrics and gynecology degree from a Harvard University affiliate. She is board certified in obstetrics and gynecology. She currently practices as a urogynecologist at Advanced Gynecology. In her practice, she addresses female pelvic disorders, urinary and bladder disorders, and reconstructive surgery. Welcome, Dr. Ford.
Thank you so much for having me. Appreciate it.
Dr. April Spencer is a Chicago native that grew up in Atlanta. She graduated from Norfolk State University and received her Doctor of Medicine degree from Morehouse School of Medicine, and also completed her general surgery residency at Morehouse School of Medicine. She completed a general surgery residency at Grady Memorial Hospital and a fellowship at MD Anderson Cancer Center in Houston, Texas. While at MD Anderson Cancer Center, Dr. Spencer was a part of several cutting-edge research as it relates to breast cancer. She believes in providing breast care with dignity and detail. Welcome, Dr. Spencer.
Thank you. Thanks for having me.
Our moderator this evening is Lolita Browning Jackson, owner of 4Cs Consulting, which offers training to small businesses, corporate, and nonprofit organizations with an emphasis on leadership, ethics, philanthropy, personal and professional development. Welcome, Lolita.
Thank you. Thank you, Angela, and welcome, ladies. So I am just going to get us started with the first question. And tonight we're talking about breast cancer and women's health. And so let's start with breast cancer. Dr. Spencer and Dr. Bowman, please share with us, what is cancer? What is breast cancer specifically?
So, April, you want me to do? I can do it.
Tag team.
Okay.
Yes.
So breast cancer, basically, it's an uncontrolled growth of cells. So we have an uncontrolled growth of cells in the breast. There's abnormalities that occur in the genes, and then the cells can grow basically uncontrolled. There's nothing there to regulate the growth or keeping them healthy. And so what that does is then when they grow without any regulation, then a tumor just continues to grow, and that's what cancer is in the body.
Thank you. Thank you. And so my first question, is there anything you want to add to that, Dr. Spencer?
I would just add that I like to give patients perspective in regards to a diagnosis of breast cancer, because oftentimes when a woman is diagnosed, they say, oh my gosh, I don't have a family history. How or why did this happen to me? And so I always just remind them from a physiological standpoint that we make cancer cells every day. That there's certain things that can trigger or turn on cancer genes to make these cells grow abnormally unchecked, like Dr. Bowman mentioned. So it's really important to engage them in redirecting their focus in terms of not focusing on why did this happen to me, but why wasn't your body equipped to recognize these abnormal cells and to control those abnormal cells. So when our body loses the ability, oftentimes we have to have some adjunctive measures where we go in and have to force the uncontrolled growth to stop. But the fact that it happened doesn't necessarily mean that they've done something wrong. It's just it helps me to engage also a conversation about things they can do to try to lower their risk in the future and make sure that they're immune.
I think Dr. Spencer is freezing up a bit. Are you guys noticing that?
Mm-hmm.
So I will
Baby, please.
wait for her to.
A lot of beeping.
Okay, Dr. Spencer, if you can hear me, I just want to let you know that you've frozen up a bit. And I'm going to continue on with the next question so that we can keep it going. And one of the things that we want to address is the CDC says that Black women and white women get breast cancer at the same rate, but Black women die from breast cancer at a higher rate than white women. And so first, Dr. Bowman, if you can share your thoughts on why this is the case, but then secondly, are these numbers decreasing as awareness is going up over the years through the internet, through more broadcasting of breast cancer awareness? So if you could share your thoughts on those or your expert opinion.
So that is correct that Black and white women have the same incidence of breast cancer, but they are dying. Black women are more likely to die from breast cancer. And the answer is we don't know why. That is something that we're trying to figure out why, because the mortality rate is so high at 40% for Black women. And we're looking into factors to see where the disparities may be, looking at the tumor biology, looking at factors like insurance and education, if there's, from the patient perspective, and then also looking at it from the healthcare or the system perspective to see why those changes or that disparity exists and why there's such a difference in the mortality rate. I think to answer your question about are those numbers decreasing?
Yeah.
Not. You can look at trends. This is not something that we've just learned. So we can look back to research from 1975 and see that Black women had a lower survival rate overall when you compare them to white women. And just knowing why, we don't know why that exists. So it's going to take a lot of work to figure that out. Mm-hmm. But I think with people like doing things like this for the community, with having physicians, like Dr. Spencer, like myself, and that are willing to spearhead that and get involved and to be the best advocate for our patients, then we can help to try to decrease that and lower that mortality rate, and so that Black women are not dying as much as they are from the same disease.
Thank you. And Dr. Spencer, with that, can you share with us why or are African American women at greater risk for breast cancer?
Sure. So one of the reasons, I have to say that in terms of the elevated risk for African American women, we're still doing a lot of research to try to pinpoint specifically what is the direct cause of that. Now, one of the things that's unique to African American women, specifically young women, defined as women that are under the age of 45, where you're seeing the highest incidence, meaning the highest number of new cases of breast cancer. So I'd like to specifically address that. And so we've looked at all things being equal, socioeconomic status, insurance, and what we're finding is that is still that disparity. And one of the things that we're looking at is that with African American women, we're the most educated demographic in the country compared to our peers, all of our peers. And so with that oftentimes comes and what I call ambition addiction, and the passionate pursuit of being the best of the best academically or in our professions. Oftentimes we're putting ourselves at higher risk because of increased stress, a lot of micro and macro aggressions in the workplace, which we've seen lots of studies to show how African American women do have a lot of micro and macro aggressions in the workplace. And that also trickles over to fertility. And I'm sure Dr. Ford can speak on that, where in many conditions, not just breast cancer, we do have a higher mortality rate just because of our lifestyle. And with this ambition addiction, oftentimes we're not able to exercise as much. There's lots of data that show a lower BMI and physical activity lowers our risk of breast cancer. A lot of young African American women, while pursuing their advanced degrees, while trying to advance their careers, oftentimes may not have the opportunity for self-care. And a lot of self-care activities do lower our risk of breast cancer. And also delayed fertility. And I'm sure Dr. Ford can speak to that. There's data to suggest that when you have delayed childbirth, your first live childbirth, that's also an increased risk for breast cancer. And so a lot of these things we don't really have a lot of conversations about. We talk a lot about screening. African American women are getting screened at 71%. Nationally, it's 70%. So we're doing great there. But in terms of self-care, I think that is where there's an opportunity to try to lower that risk a bit in terms of exercise and de-stressing, and making sure that we're getting, the proper rest and self-care to keep our risk as low as possible.
Thank you. Thank you. And while we are discussing breast cancer, women's health is all encompassing. And so, Dr. Ford, please explain to us when a person would need to see a urogynecologist.
So that's a great question, Lolita, and it's one that is often confusing to a lot of people, even physicians. So I really appreciate this sort of platform to delineate that a little bit. But essentially, a urogynecologist is sort of a mix between a urologist and a gynecologist. So we're essentially experts in the pelvic floor and pelvic floor disorders. So what that means are women who tend to typically be older postmenopausal, but this can also happen in premenopausal women, women who experience things like urinary incontinence or leakage of urine, fecal incontinence or leakage of stool, pelvic pain or prolapse. So that's basically the vagina, the uterus, sort of the bladder coming down and creating a bulge in the vagina, which can be uncomfortable, it can be unsightly, it can be a really serious health risk in that when prolapse gets advanced, women can stop being able to urinate completely or being able to empty their bowels. So I essentially am a vaginal or pelvic reconstructive surgeon, but I manage a lot of these disorders non-surgically. But that's sort of what I do in a nutshell. There are some little here and there sorts of things that I'm sort of a person where if other doctors, other OBGYNs are looking at a woman's vagina and they just don't know what they're looking at, sometimes, there are bulges or things that are out of place and they're not sure what that is, they send them to me. So that is mostly what I do. But from a patient standpoint, especially in a Black female population, one of the biggest issues that's really not talked about a lot is maybe not urinary incontinence, but urinary frequency and urgency, and needing to use the restroom, so much so that it is interfering with your life. Mm-hmm. That is a lot of what I do. So that's a big part of it. But thanks.
Thank you. Thank you. And I have a few more questions for you also, but I want to get back to Dr. Spencer. When you were talking, you mentioned younger women and breast cancer. And today, are you treating younger women? Are younger women being diagnosed with breast cancer more? And why is that? And what is the age that you're seeing this occur?
Okay. I think what I'm seeing, and I'm sure Dr. Bowman will agree, usually in our practices, it oftentimes reflect what's seen in the general population. And so I am seeing, just like what the national observation is, increasing African-American women 45 and younger with a new diagnosis of breast cancer. So there is an increased incidence or increased number of new cases in women in this specific demographic. And so, so I am seeing that. And it's very frustrating group because oftentimes they present at a later stage. Oftentimes, their tumors are more aggressive in terms of the grade or tumor behavior and tumor biology. Oftentimes, these women have special receptors, commonly known as triple negative, where all three receptors, estrogen, progesterone, and HER2, are absent, which can make it a little bit more challenging to treat. And many times, these women need to have a more aggressive treatment plan, many needing chemotherapy prior to surgery. And from a psychosocial standpoint, a lot of these are young women, newly married, or have young children, and they're in the very beginning or the most robust stages of their career. So it can be very disruptive to their livelihood in terms of being able to have childcare and being able to make sure that they're able to keep their jobs or their careers going in the midst of treatments. I don't know if oftentimes there's some delays in workup because you're getting these women really at the height of their careers. And so oftentimes it's difficult to shift and pause to go back, when you have that abnormal mammogram. And I tell women, if you get a call back, go back. And because we're getting the mammograms, we're doing great there with a lot of screening programs with Susan Komen and the Lights, encouraging screening. So we've made wonderful strides. We get screened at a higher rate than any other demographic at 71%. But oftentimes when we're following up with treatment or just following up after you get that abnormal mammogram is where we see some opportunities to really impact the outcomes of these younger women. Are you seeing that as well?
That was my question, Dr. Bowman. Are you seeing that?
Yes, I completely agree with what Dr. Spencer said. I think one thing that she touched on too is like we're great at screening, but the follow-up is where it lacks sometimes. But I also think that a lot of patients or a lot of women, particularly young women, especially if it doesn't run in the family, even if they get that screening mammogram done and it says, call back, they will think maybe there's a delay, maybe not necessarily denial, but just thinking, not making it a priority because I don't have a family history. And that is something that we try to educate patients and women to know that, cancer doesn't discriminate. And just because you don't have a family history does not mean that you are immune. But yes, we do see it. I see it just like, Dr. Spencer said, just like what we're seeing, nationally, that we're seeing much, much younger women with.
So a question actually from our audience, what is the youngest age that you all may be seeing with breast cancer diagnosis?
So for me personally, my youngest patient was between 19 to 20, and they didn't have a family history. Initially when I first met with them, but they actually had gene testing. It was negative, but then once going through gene testing, found out she didn't know her father's side of the family. And so when she went through that information with a genetic counselor, learned that it actually was very prevalent in her family, but she didn't have any gene mutations. But I always tell patients this as well, is that we know a lot of information, but we don't know everything. And we don't know all gene mutations or everything that would make you at increased risk. But I've seen younger patients as young as, 20s, and it's so sad.
Yeah. Is that the same for you, Dr. Spencer?
Yeah, I'm seeing the youngest in the early 20s. And it's good that Dr. Bowman emphasized the lack of family history or not having a breast cancer gene be positive, to not allow that to dissuade you from following up on things. In terms of the numbers, only like 5 to 10% of women that are newly diagnosed with breast cancer will carry the gene. And we're not aware of all of the genes. She said that perfectly, because oftentimes patients will say, well, I test negative, but every woman in my family has had breast cancer. How do we not have the gene? And it's like we have cracked the genetic code, but we don't know what all of these genes are capable of doing. So in the meantime, we've got to be diligent. You've got to continue to have panels like this so we can educate and try to help dispel the myths, but also encourage women to still make sure if they see something, say something, and to follow up on any abnormal mammograms, or if anything is not their standard, what they're used to in terms of bodies, to make sure they let someone know right away.
Yes, yes. Thank you. Thank you. Dr. Ford, so if a person has been treated for breast cancer and it's believed to have spread to the uterus and the bladder, what's the next step for them as a patient?
Well, I would say, from a urogynecologic standpoint, I would definitely refer that patient to an oncologist, someone who deals with cancer primarily. That would be the next step, to have an evaluation with a cancer doctor. I specifically am not a cancer physician. I've certainly, in my job, diagnosed cancer. These are women who have various symptoms like urinary frequency, urgency, that sort of thing. And that is as a result of a bladder cancer or a vaginal tumor or a uterine tumor, and I come across that in my workup. But certainly, I would have that person see a gynecologic oncologist or a urologic oncologist if that was in the bladder or in the uterus.
And so with younger women, are you seeing more younger women with urinary or pelvic disorders today?
Yeah. It's so interesting in that I think almost the trends are reversing slightly. If you think about delayed childbearing being something that we're seeing with women being in the workplace and things like that, pelvic organ prolapse used to be a really severe issue for young women working in the fields, working on farms, doing heavy lifting, having multiple babies very early. And now we don't really see that as much. And we do see later onset of a lot of these things. But I'll say, in most of my patients are postmenopausal, but certainly I think if women in their 20s and 30s maybe ask some of their friends or themselves who have had children and say, do you leak a little when you cough or laugh or sneeze? That's something that so many women, it's ubiquitous that a lot of women think it's just normal. And so that's called stress urinary incontinence, the leaking with cough, laugh, sneeze, exercise, sex can be a part of that. A lot of women experience that in pregnancy, not necessarily just after having babies. And it's become so normalized that, they often don't mention it to their physicians, don't mention it even to their friends. But it is extremely, extremely common. When we get into some of the more difficult issues that happen from a urogynecologic standpoint, like prolapse, those are things that typically take decades to happen. And so we do see those later on in life. But, I've operated on women who are in their teens who have had prolapse. And those are women who typically have some sort of genetic component or like a collagen tissue disorder. So that's uncommon. But I would say that leaking with cough, laugh, sneeze, that is very common. I see a lot of patients in their 20s with that.
Okay, thanks for explaining that. And Dr. Spencer and Dr. Bowman, as we see some of the changes in what's happening, we're seeing, women having children later. We're seeing just some of the changes. And with that, is there new technology? Is there anything that we can look forward to and cures and treatment with breast cancer?
I think one of the things in terms of radiation, it's not necessarily new in the medical community, but more women are becoming aware of a shortened period of radiation, where typically a woman would get radiation for certain types of breast cancer every day for 6 weeks, which is a huge time and emotional commitment. And now people are a little bit more aware of brachytherapy, where it's partial breast radiation, meaning only the part of the breast that's affected with breast cancer is radiated. And usually those women can have their radiation completed in 5 to 6 days versus 5 to 6 weeks. Now, of course, this select group of women, have to meet somewhat safe criteria in terms of the age and size of the tumor and whether or not lymph nodes are involved, but that's something that's very promising.
Okay.
And in regards to just therapy, we call systemic therapy, the type of therapy that goes in the veins, we are able to now look at the tumor behavior and biology. I know Dr. Bowman has mentioned the behavior and biology. I'm so glad she mentioned that, because so many times we focus a lot on stage because that's all we've heard about for 20, 30 years. But we can now have the medical oncologist, which is the doctor that may come up with the plan for chemotherapy, to devise a treatment plan that's specific to your tumor behavior and biology. And so they'll look at special numbers. One such study is Oncotype score. But if the score is low, that means you will likely do well with or without chemotherapy. If that score is high, that suggests that chemotherapy would be more helpful than harmful. But it's great that we now have objective data, like actual information from the specific tumor, so that patients can get a very individualized treatment plan. And this is encouraging to a lot of women in terms of technology, because now they don't have to automatically assume, oh my gosh, I have breast cancer, I'm going to need the same thing my neighbor had 10 years ago, which is the radiation, the chemotherapy. But we have tools in which to come up with a more catered treatment plan, which oftentimes will lower the side effects or mitigate against that, and have maximum efficacy and minimal toxicity. So, I think those are wonderful strides.
Thank you. Anything you would like to add, Dr. Bowman?
Yeah, just one thing. And so just what Dr. Spencer said about individualizing treatment. The advances in medicine and with radiation, there's been a tremendous amount of advances in surgery. But one of the things we're also looking at now and consistently or continuously try to look at is the need for complete removal of all lymph nodes from under the arm. And so for decades now, we've been able to eliminate it in some patients when they do a lumpectomy. But now studies are also being done, because those patients with a lumpectomy get radiation, but studies are also being done to see if we can, eliminate it from patients who get mastectomy. And especially if radiation is going to be done, because the biggest thing or the biggest risk for when you remove lymph nodes is having lymphedema, which is swelling of the arm, which can be, really have a great impact on someone's life, like just for the future. And so with that increased morbidity, we're seeing if we can achieve the same overall survival benefit with not having to remove the lymph nodes from under the arm. So we're not yet there, but breast surgery and breast treatment is changing almost on a daily basis. But we're really trying to make strides to keep advancing treatment and keep advancing the technology so that we can individualize treatment and have a patients survive from disease, but not have a great morbidity or a lot of side effects with it.
Okay, thank you. And so all of you do surgery. I know for Dr. Spencer and Dr. Bowman, you are surgical oncologists. So first I want you to explain specifically surgical oncology, but then I do have a question about that, and that is surgery always the answer? And when are times when you can recommend other alternative treatments? Surgical oncology.
Okay. So surgical oncology, in general terms, are surgeons that treat cancer. And so we are breast surgical oncologists. We're specialists. We've done general surgery, but our specialty is in breast surgery. And so both she and I treat cancer. We also treat benign disease as well.
Okay.
And so when we're breast surgical oncologists or breast surgeons, but the biggest thing is that that's what we do 24/7. We don't treat other parts of the body, so to speak. We specialize specifically in breast. We've done fellowships, which are extra training after our general residencies, that allow us to be, specialists in that field. So that's what we do. So that's what a breast surgical oncologist is.
And so generally, if someone is diagnosed and they need to have surgery, you're likely that they will come to you to remove the cancerous cells.
Correct.
Right.
There are some general surgeons that practice breast surgery. And there are some surgical oncologists that have done a surgical oncology fellowship, but it's more of a broader, they treat broader spectrum of disease, and they also can treat breast. But with there being a specific breast fellowship, there are a lot of specific, surgeons that just do breast surgery. And so ideally, I would recommend that patients try to see a breast specialist.
Yeah,
Okay.
I concur. So, yeah. And it's kind of like, if you were to, need your gallbladder removed, either myself or Aaron can take it out, but it might take a little bit longer and with less finesse than someone that does it every day. And I tell women, just like when you're getting your hair routine or any sort of beauty regimen, you can have someone to, style your hair, but you may go to a colorist to have the color done. So, we need to have these specific specialists that's all they do. And I know people tend to do better or much better when you have a specialist. Now, there's data to show, of course, like she mentioned, general surgeons or surgical oncologists can do a fine job removing it. But oftentimes we are more abreast, no pun intended, and seeing this every day and managing it every day. And to answer your second question in terms of if surgery is not always the answer,
Right.
I can only answer for myself, so I'm a little biased.
Right, exactly.
Season. But there are certain small benign or non-cancerous tumors that we're treating with cryotherapy, where you're just freezing them intraoperatively. But there's still a lot of data that suggests that physical removal of the assaulting tumor is the best strategy in terms of getting tumors under control. And I don't know if Dr. Bowman sees this in her practice, but I come across women every week that's coming to me for a second or third opinion that were diagnosed with breast cancer 2 and 3, sometimes 5 years ago. And it's now progressed, it's metastasized because they have been trying to forego traditional treatment. I don't want surgery. I don't want chemotherapy. I don't want radiation. I just did my vitamin infusions and saw a naturopath, and they put me on this holistic journey. And this is not, they're not regulated by the FDA. Oftentimes these women are paying cash, and oftentimes when the disease progresses or the cash runs out, then they see a traditional surgeon like myself or Dr. Bowman, and now all of a sudden they want surgery, chemo, and radiation. And oftentimes we may have missed that window, that surgical window, to have an impact on the disease because it's spread so much where it's now not curative, but more so palliative or controlling it so that it's not, spreading as quickly. But it's so important that patients don't get this confused and say that, no, we don't want you to have your supplements. I think they have their place, but it should not replace surgery, chemo, radiation, if those things have been recommended by your physician. I cannot emphasize that enough. And I know that wasn't a part of the question, but it just breaks my heart when these women come back after you've seen them 5 years ago, and for whatever reasons, they've decided not to have surgery or have any treatment, and it progresses and the window is lost.
No, thank you. That's good information to know and good information to share. Dr. Ford, you do surgery as well. When is there a time when you may have to do a pelvic surgery or pelvic reconstruction? What is a woman seeing? What's happening when you have to do surgery?
I think there may not be a starker discrepancy between our specialties here, because for me, from a urogynecologic standpoint, it's never too late. That's kind of our motto. Some women, they've had these issues and maybe they've been dealing with their kids or their grandkids or whatever. And finally they're 75, 80, 90, 100. I've operated on a 110-year-old woman. it is the epitome of elective surgery. So it's when it is comfortable for you. I don't do any preventative surgery. There's no role for prevention from a surgical standpoint. As a urogynecologist, I always say, we're going to do surgery for what you're feeling now, not what you may be feeling 10 years, to avoid what you might be feeling 10 years later, because the natural history or the progression of prolapse or urinary incontinence, it is not well established at all. And so some people, they say, what happens if I wait 10 years? We literally don't know. It might be exactly the same as it is now. It might be worse, but ask yourself right now, if your issues are bothersome enough to, undergo anesthesia and have a surgery for them, then we should do it now. And like I said, some women say, well, I think I'm too old for this. I can't, manage this. And that is almost never the case. That age really doesn't play a big part in what we do, because again, what I do is operate on issues that address elderly women typically. So cannot make a bigger distinction between our specialties in this area.
Okay. And so at what age would you say women actually are coming to you as a urogynecologist?
That's a great question. I'll say this, when it comes to urinary incontinence, it typically happens when women cannot use panty liners anymore, and they're now into the thicker, heavier pads, and you can't really manage with, it's something you have to constantly think about. And that it happens at a lot of ages, but menopause really changes a lot in terms of the pelvic floor function. And so menopause is usually when sort of the straw breaks the camel's back. So, the average age is about 51. And I usually see people in and around kind of that time. But I am so pleased when people see me earlier, because there is a role for some preventative exercises, some preventative treatments from a urologic and a gynecologic standpoint. And when I see women who say, you know what, this is weird, this hasn't happened to me before, I just want to check it out, this thing happened 2 weeks ago, I love it, because it is a conversation where you don't have to wait till you're in diapers, to come see me. You don't have to wait until your prolapse is hanging down to your knees before you come see me. There are things that we can do before that. But I would say, 50-ish, menopause is usually that time.
Okay. And do you do things that control hot flashes?
It is not my special. So I'm OBGYN trained. I'm board certified OBGYN. So of course, menopause is something that I manage. But like Dr. Bowman and Dr. Spencer have mentioned, there are people who just do menopause.
Okay.
And, for the run of the mill patient, there's a pretty standard regimen of sort of what we do. If that doesn't work, I send you to a specialist, because those are folks who that's all they do. And in the same vein, as maybe Dr. Bowman and Dr. Spencer, they can do a cholecystectomy. They can take your gallbladder out. It may not be the most beautiful thing in the world. There's just, we live in a place where there are an abundant amount of specialists who can manage various different things. And just to sort of put a plug in for urogynecologists, there aren't a whole lot of us around, but, if you're a woman with a pelvic floor disorder, there are some gynecologists who can treat that. There are some urologists who can treat that. But what I do is just that all day, every day. So, if you don't have to go to the person who just dibbles and dabbles, and can go to the person who did, their extra training, 11 years of training in that, that's the person who I would go to. So to answer your question, if your only issue is menopause and hot flashes, there are better people to see. But a lot of times that comes along with something called the genitourinary syndrome of menopause, which is what I am an expert in. That are kind of all the things that I talked about, which don't get mentioned in the hot flashes, night sweats,
Mhm.
dry vagina. They sort of get buried down, and women don't really know what these other things are. And it's menopause just manifesting in the vagina.
Oh, okay. Okay. That's good. Thank you for explaining that. So I'm going to go back to breast cancer. I have a question about triple negative. And the question is, why do Black women develop triple negative more often than white women? Dr. Bowman, Dr. Spencer.
Yeah, well, we're still trying to do research to figure out like why African American Hispanic women specifically are at increased risk for triple negative. For those that are watching that may not know what triple negative is, there are 3 receptors, hence the term triple, that we oftentimes, or the medical oncologists will target
Mhm.
to turn off those genes that are multiplying. And Dr. Bowman mentioned that cancer cells are just cells that don't get the signal to stop growing, it's just uncontrolled cell growth. And so we look at a tumor like a light, and you want to turn off the light. But if you lack the switches, you can see how it's very challenging to turn that light off when the light switch isn't there. So there are 2 out of the 3 switches that we use, with estrogen being one and HER2 being the other, that when that is overly stimulated or stimulating the cancer, we try to turn those switches off. And so there's more research that needs to be done on African American women. And I'm glad you asked that question, because there's an opportunity for us to answer that question by engaging in clinical trials. And many of the clinical trials, African American women are underrepresented. Now, we know historically many of us have a huge stain or general mistrust of the healthcare system, specifically research with the Tuskegee experiment, many others, Henrietta Lacks, where things were done without our permission. And so there is that mistrust. So that's why it's so important that we have panel discussions where women can see other women that look like myself and Dr. Bowman and Dr. Ford, where they know that they can trust us. And so we are encouraging you to engage in clinical trials. We need your help to help save lives, but we can't get those answers unless you are engaging in the clinical trial. So I really want to encourage those that are watching, if you have a family member or a friend or a neighbor, a coworker that has been diagnosed with breast cancer, to encourage them, if it is available, to engage in a clinical trial, just so we can try to get more information and hopefully have the answer to that very important question as to why we have it at a higher rate.
Thank you. Thank you. Dr. Bowman, anything you would like to add to that question, to that answer?
Just along the same lines with the clinical trials is for patients to understand that what we're trying to do is change the narrative of, one size fits all, like one treatment should treat all. And we can look at studies. We know, Dr. Spencer and I, and even Dr. Ford, I'm sure, in the urogynecology world, you can look at studies and see that the subjects are not minority rich. So they may find treatments that work for cancers, but if we're seeing these different rates and seeing Black women having triple negative breast cancer, and maybe not surviving or not doing as well, it could be because the treatments that we found maybe aren't working for some reason that we don't know. And so, I want to piggyback on what she said about, the importance of clinical trials, the importance of us being a part of studying those treatments and perhaps being in for treatment advances, so that we can specialize medicine and specialize what's needed, perhaps based on race. There's differences that exist. And so, if we're not a part of it, we're not going to have those treatments.
Thank you. And so as it relates to triple negative, the next question is it recommended that if you have triple negative cancer, that you also have a hysterectomy?
No.
No. Okay.
No. And just to add some hormonal clarity, and Dr. Ford, you can jump in at any point that you like. 85% of tumors usually are stimulated by estrogen, meaning they're estrogen positive. The person will have a tumor that has an estrogen profile that's feeding the tumor. And so if it's triple negative, that means the estrogen is not present. So it's not necessarily stimulating that. One source of estrogen, of course, is in the is from the ovaries. So if that person lacks an estrogen positive tumor, then it really wouldn't benefit them to have their uterus and ovaries removed, because they don't have a type of tumor that's being stimulated by estrogen if it's estrogen negative, as are triple negative tumors. That means it lacks estrogen stimulating component, progesterone, and HER2. And so to answer that question, the answer is no, that is not beneficial. Now, where that might be beneficial is in women that have been diagnosed with a breast cancer gene that puts them at increased risk for both breast and ovarian cancer with the BRCA BRCA1 gene. They may want to have a conversation about removing their ovaries, since that can stimulate it, but there are other ways in which to suppress estrogen, like exercise and via medicinal or estrogen blocking pills. But I'm a huge proponent of women keeping their pelvic organs when they can, when it's necessary, but I would not agree that that particular example would be necessary.
Thank you. Thank you. And so one of the things we really have not talked about, but we all know is very important, and that's screening. And so my next question is, we talked a lot about having the gene, you just mentioned a gene, the BRCA1 gene, and I guess that is because of a family history of breast cancer. So one, I want to talk about screenings and when you should start getting screened, but then also if you have a family history, when should you begin getting screenings for breast cancer? Dr. Bowman, Dr. Spencer.
Sure. For the average risk woman, the recommendation is to start at age 40 and continue annually. When you have a family history, if you are higher risk, then that may change. And so typically what we recommend is 10 years younger than the age of the earliest diagnosis, as long as it doesn't go over the age of 40. So for example, if a mother was diagnosed at age 39, then her daughter would then start screening at 29, so 10 years younger than the age of diagnosis. We screen for patients for high risk, but basically there are lots of risk calculators and models that we use that are largely based off of family history, but to determine if you fall into the high risk criteria or not for other modalities as well, like MRI. But for screening mammogram, the average risk woman starts at age 40. And like I said, that may change based off of your family history. But in order to know if that's the case for you, it's important to talk to a healthcare provider to see if you fall into that category to be screened at a higher risk or screened earlier age.
Thank you. Thank you. And so I understand that there are different types of breast cancer. So, and I'm going to ask this question first. What are there symptoms that we talk about screening, and we talk about the importance of getting screening, and we know that you can get a mammogram and you can do self-screenings, but does someone experience any type of symptoms if they have breast cancer?
That's a really good question, because most women, when they think of having symptoms of breast cancer, they oftentimes will reflex to a lump. And that is, okay, I do my monthly breast exam, and if I feel a lump, that they know that that's a red flag. But oftentimes women will talk ourselves out of the other signs and symptoms. Either we're not aware, or we might be aware and just somewhat in denial. So some examples of signs would be inversion of the nipple that wasn't there when your breast started to develop. Why does that happen? Because sometimes there can be a lump that's growing that you can't feel at all, but as it's growing, it's pulling the nipple inward with it as it's growing. And so that is one sign, nipple inversion. The other thing is oftentimes women will ignore a rash or changes in the color of their breasts. There's a very rare type of breast cancer called inflammatory breast cancer, where about 75% of the breast is red, hot, and swollen. And many women will be treated with antibiotics. They'll think maybe I have a mastitis or a bug bite and have a treatment that is geared more towards an infection when indeed it is an inflammatory breast cancer. And also just be mindful of what's going on in terms of the shape of the breast and the underarm, because the lymph nodes are there and sometimes those can be swollen. That could be a sign of breast cancer. And even itching of the nipple can also be a sign of breast cancer. But the bottom line is, we oftentimes don't emphasize doing the monthly breast exam as much anymore, simply because a lot of the national organizations have noticed that in terms of behavior and what women are reporting, if it's not a lump, they don't think that it's problematic. We don't think it's problematic. So the main thing is just to know what your normal is. And if there's something that deviates from that, to let someone know, your healthcare provider know right away, not just look and feel for a lump. So again, nipple discharge, I didn't mention that, but nipple discharge, nipple inversion, itchiness of the nipple, skin changes in the size and shape of the breast. Like I had a lady that I saw, her breast had increased in size on one side, and she thought maybe because she was working out, but she ended up having a rare type of breast cancer. But had she not mentioned, she ended up having Paget's disease, but it led us to diagnose her with breast cancer. She did not have a lump, just a itching of the nipple and a slight change in the size of her breast, which warranted a screening, a diagnostic mammogram, which is a mammogram in the presence of symptoms. And she was 39, so she had not yet reached the screening age and didn't have any mammograms to compare it to. But I'm glad she was at least diligent to know that, this is not getting better with the steroid cream that my primary care has prescribed. This has not gotten better from the creams that my dermatologist has been going on for 6 months. By the time she was diagnosed, she had gone with treatment that was really suboptimal for something that she didn't have, because again, she didn't have a lump, so she didn't really think it was problematic.
Thank you for sharing that. And thank each of you. Before we close, I would like for each of you to share a message tonight for our viewers that you believe is important as it relates to breast cancer, as it relates to urogynecology. And while you're thinking about that, I do want to share that we have some resources that we want to share with everyone as it relates to breast cancer. And so thank you. We have those resources on the screen, the Advanced Gynecology, the Atlanta Breast Care, Komen Breast Cancer Foundation, of course, Dr. Spencer's Global Breast Health and Wellness, Metro Surgical Associates, and Sisters by Choice. And so thank you all so much for your time tonight. And I'll just like to close with each of you just sharing your message and what you want women to know, and even men I know get breast cancer. And so what would each of you like to leave with our audience? What message? We can start with Dr. Ford.
Sure. I'm kind of the outlier on the panel. I always sort of revert to this pretty simple phrase for urogynecologic issues, which is things may be common, but that doesn't mean they're normal. And so that really refers to, urinary issues, pelvic organ prolapse, pain. As much as those things are common, it doesn't mean that those are things that you have to live with. And there are specialists who, like myself, this is literally all I do all day long, is take care of people who leak urine, leak stool, have pain in the vagina, have, various numerous different types of issues. But just to make sure that you're aware of these types of specialists, and that, it's not something that you have to live with. So common doesn't always mean normal.
Right. Thank you. Dr. Bowman?
Sure. I would say for women, to be your own advocate, to ask questions, to talk to your family, know your family history, ask your healthcare provider, do you need to have screening start earlier? than the age 40. One thing we didn't really go into, but ask them, do you need to have a 3D mammogram if you have dense breast tissue? Or, just
Right.
ask questions, to make sure that you're getting what's needed for you. And then modify risk factors that, you can change. We can't change being a woman. We can't change getting older, but there are things like diet and exercise, things that can lower your risk, that you can do to lower your risk for developing breast cancer. And so kind of just that the one liner is just, yourself, and you should treat yourself so that you can live your best life. And so be your own advocate.
Definitely, definitely. And Dr. Spencer.
Sure. I think she summed it up very nicely. I would just encourage women to just remember the ABCs of what we all been chatting about tonight. And the A is just being aware of your anatomy and aware of the screening guidelines. And B is just behavior. There are things that you can do. Like, Dr. Bowman mentioned, you can't really change your age or your gender, but things that you can do like exercising, being mindful of what you're eating, de-stressing, engaging in self-care to lower that risk. And lastly, C is just consumer choices. Just being mindful every time we sit down to eat, we either feeding disease or fighting disease. Being mindful of what you're putting in your bodies and on your bodies, because there are a lot of carcinogens that are out there in our beauty products and things that we do in our everyday regimen or routine, just being a woman. And so just be mindful of that to lower your risk. And then for those women and men that have been diagnosed with breast cancer, I always like to encourage them to let them know that you may have been diagnosed with breast cancer, but it doesn't have you. Make sure you get with a good care team. Again, be your own advocate. If you see something, say something. If you get a call back, go back. And, bump in the breast is like a bump in the road. You've got to get over it, go under it, go around it. But, failure or not doing something is not an option. So just find a good care team that you trust and get a second or third or fourth opinion if you have to. But you don't want the fear to cause you to lose your life because of, the fears of the treatment or not being on the same page with your team. So, that is what I want to leave people with, just to be encouraged and know that this is something that you can get through with a really good team.
Thank you all so much. Those were wonderful words. Thank you for sharing. Thank you for your expertise. And on behalf of everyone in the Camellia Rose chapter of the Links Incorporated, we want to say thank you, and we appreciate you. And we, of course, want to remind everyone I know this is October and it's Breast Cancer Awareness Month, but whenever you go, get your mammogram and, do the self-checks, but I think everyone says, know your body, know what's happening with you, but make sure you get those mammograms done annually every year. And I also want to share with all of you that this is being recorded. So if you want to share it with your friends and family, you can. And if you out there, feel like there's someone that needs to hear this discussion, that needs to hear some of these details, please share it on your social media. Thank you. Thanks, everyone. Have a wonderful night.
Thank you, you too.
Thank you. Take care.
Thank you.
Thanks.